Good day. My name is Jennie Joseph, and this is my presentation. So today I'm talking about saving lives, something that's very near and dear to all our hearts. And I know that wherever you are in the world, that is a priority when it comes to mother, baby, family. I work in the United States of America. I've lived in the United States since 1989, so that's 31 years at this point. But I was born and raised in England and educated in England as a midwife in 1979. So I've been doing my work a long time, but since I moved to the United States, I've had a different dilemma and a different approach to the work that I do. This picture is from one of the patients in my clinic here in Orlando in Central Florida. And we captured a series of black and white photos of the women in the practice many years ago now. This child is probably 12 years old at this point. But we thought it was so poignant to be able to capture images of Black women, particularly where there's such a continued dearth of images of Black women, healthy Black women, pregnant or parenting Black women that are positive and powerful. So, as I said, I was educated in England. Here I am graduating in 1981 as a staff midwife in Edgware General Hospital in England. And I've got a practice now in Orlando where I serve women from across all socioeconomic strata, but women who are not even specifically looking for midwifery care. I've been doing that work for 20 plus years in the Orlando area. And I work in a birthing center and a clinic that I own and that I use the midwifery model of care to promote health and safety. And including my local work, I've developed and created a national presence around midwifery and the impact of using midwifery to make pregnancy safer for women. In my case, I'm focused particularly on Black women, African American women, and Indigenous and Native American women who are suffering most desperately as far as maternal health, maternal mortality, and maternal morbidity in the United States. We were lucky enough to be featured in the New York Times in the United States in 2018, a story that explained the work that we're doing in Florida and how effective it is as far as working on saving lives for Black women and women of color. This picture is another one of my patients. I put this picture in the show because I wanted to just illustrate that actually it does that. Things can work well. Maternity care is safe. Maternity care is possible in the United States, but seemingly more likely for white women. And this is one of the biggest problems that we have. When we compare Black women to white women, Black women are suffering at 3 to 4 times the rate of white women when it comes to dying. This is a patient of mine that we were doing a birth center birth, a community-based birth. And although you can't really see under that towel, she just delivered a 10-pound, 8-ounce baby vaginally in the hospital. And so you see the centering of the care that happened there and how joyous she was and how happy we all were with an outcome because we managed to get what we were looking for. The birth plan was respected and mother and baby was safe. So that's not what's happening in the United States. What we're seeing in the United States, on the other hand, is the need for public health goals to address and really attack the problem. And the problem is that health disparities are rife, and the problem is that we don't have health equity. So every 10 years, the government makes very strong and lofty goals and makes a good effort, but we're not getting very far. And I'm here to say that we have to do better. We have to try harder. So, for example, in the year 2000, the Healthy People 2010 goals were set and included public health goals across the spectrum, but called for the elimination of health disparities. Well, 2010 came and went. And by 2020, we had another set. Well, in 2010, we set another set of goals, Healthy People 2020 goals. Same thing, let's eliminate health disparities, but now let's get really crazy and go for, we want health equity in 10 years. And we also want to improve the health of all groups. There are Healthy People 2030 goals. I haven't posted them here. Anybody who wants to look can look at the healthypeople.gov website for more information. What we do see consistently and unfortunately every 10 years, not much change in any type of data Look at this graph. It's very common. This is a preterm birth graph in Orange County, Florida, where I live. But it could be cancer rates. It could be blood pressure rates. It could be anything. But you know, there's always going to be a very markedly higher line above the general population, all the races in the general population. The one line that's going to be sky high and way above everybody else is going to be the Black race. So let's just put it another way. Our babies are dying. Black babies are dying. Twice as many babies born to African-American women are dying because they're being born too soon, too small, too sick to survive that first year of life. The infant mortality statistics have not changed in a very long time. Even when we get a drop, we have the disparity. And yes, women are dying too, and that's the topic I'm talking about today. How are we going to address this issue? Because from my perspective, and many others who think the same way as I do, this is a justice issue. 2 to 3 women die every day in the United States, but there is a really important statistic hidden inside of that. The figure could be 50,000, it could be 60,000, it could be 100,000, it could be 500,000. We don't know how many people nearly die in the United States every year. That's what's really important here. Women dying, yes, but nearly dying in a country that is so overly resourced, is so affluent, has all of the means to make sure these things don't happen. It's not doing very well at making sure these things don't happen. 3 to 4 times as many African-American women are dying as white women. This picture is when I was on Capitol Hill in 2010, and that's when we first came out with this work. Amnesty International was a leader on pointing out the maternal health issue in the United States. So let's look at what some of those causes might be, because we know these are preventable deaths for the most part. What we see here is that we have this propensity, if you will, to say, well, it's the social determinants of health. Of course, if women come from poor neighborhoods, if they have violence in the neighborhoods, stress, and they have food deserts, they don't have what they need, of course, they're not going to have a healthy pregnancy outcome. Well, so the social determinants of health, they do have some very large impact, of course. But what I want to speak about, and the name that I gave to this common problem, I call it maternal toxicity. And so, yes, neighborhoods, areas where people live could be considered maternal toxic, meaning not really healthy for mothers and babies, meaning that you yourself wouldn't want to live in such an area if you were expecting or parenting a young baby. But there's another part about maternal toxic that is worth speaking about here. For me, maternal toxic can pop up anywhere a person of color is or a person who is marginalized is. And so by that, I mean, you could actually have maternal toxicity impacting your health and well-being inside of a hospital, for example. So again, the same woman I showed earlier who had that perfect outcome, she managed to vaginally deliver her macrosomic baby. But you can see here that this is when we first arrived. She was using the oxygen. The nurse was helping us get her settled. The physician came in and delivered this child. But for other women, women of other race, other ethnicity, other status, marginalized in some way, the hospital is not necessarily the safest place. You would think it would be, but in actuality, that's not the case. So I want to really just stress that the maternal toxic area or zone or environment can pop up anywhere. So if you didn't know the story about Serena Williams and her recent delivery a couple of years ago, Serena Williams nearly died because she was being ignored in a hospital. Many of our maternal deaths or morbidity are exacerbated by being in supposed safe zones, areas where somebody is there to help you, but is actually not helping you. Why? Maybe because of implicit bias, unconscious prejudice, structural and deeply held ways of being, historical inequities and injustice. That is also as lethal as the medical and physiological concerns that we talk about more often. I want to use this story to illustrate how that plays out. This young lady actually came in for her clinic appointment to one of our clinics, and turned out she was laboring. When I examined her, she was 8 centimeters dilated. So she had planned a hospital birth, as many of our patients do. The majority of American women choose hospital for their deliveries. That's what they feel is safe. That's what they feel accustomed to. So this young woman was ready for her hospital birth, but didn't realize she was in active labor, in fact, transition. So we called the ambulance to bring her from our clinic to the hospital. hospital, and I felt like I should ride with her in the ambulance because of her imminent delivery. And sure enough, en route, she had the baby in the ambulance. So you can see her just newly delivered, still in the ambulance on the stretcher. You can see the look of shock on her face. Baby's lovely, pink, and I have the baby skin to skin. By the time we reached the hospital, we had the baby right there, right close to mom's breast, and mom is beginning to kind of come back into her own. And we made the transfer from the ambulance into the hospital emergency department and explained what had happened en route. Everybody started running around like we do. For some reason, although that's what we are there to do, we end up like rushing and like chickens, like with our heads cut off because somebody had a baby in an ambulance. Oh my gosh. Anyway, I wanted you to see how beautifully well this child was doing, and also how this mother came to this place of just that usual mother bliss in that golden hour. So even in a situation where she was having an unexpected situation, where she was well taken care of, en route to the hospital, well taken care of when she arrived, the change in the response to her, we presume because of her color, because there was no other reason to have a response to her. You see the baby healthy, you see the mother healthy, you see everything under control. Everything went crazy from there, including an almost argument about who was going to deliver the placenta because of the relationship to money and insurance claims and all of these different pieces, as this part was still now under the auspices of the hospital that we had arrived at. Worse yet, and this is the point of this story, when she was admitted to the labor and delivery ward as a postpartum mother, she was about to breastfeed her baby, which was her wish. She wanted to breastfeed. And the nurse took the baby and said, no, baby had to have a formula feeding because the baby was born out of hospital. And the nurse felt that this baby needed to have its blood sugar checked and needed to have that formula. Mother lost the opportunity to breastfeed initially, and it did impact her breastfeeding experience. And she ultimately did not breastfeed this baby. This is the type of toxicity that I'm talking about. You would not expect that to be part of this story because these pictures illustrate something completely different. Yet, for whatever reason, structural and institutional biases, ways of thinking, individualized biases, racism, prejudice, whatever, this child, this mother-baby pair, their bonding was interrupted. And when there was a very normal and physiological birth experience that happened inadvertently in the ambulance, but it's what happened. So let me go back. What does real quality perinatal care look like anyway? Is it the building? Is it the cost of the services, number of services, the interventions? Is it the practitioner? Oh, is it a midwife better than a doctor, doctor better than a midwife? What is it? Or is it about the will to always and every time provide quality care for mothers and babies? We all know this work thanks to Professor Vedam and her team out of British Columbia. 1 in 6 women are experiencing mistreatment during childbirth. This is the United States. People of color experience more mistreatment in birth. Again, America. What are we doing? The types of mistreatment, just outrageous and continual, and must have an impact on birth outcomes and health and well-being of women, particularly women of color. So what does culturally safe perinatal care look like, and how do we get there? My questions for you to consider is, how does providing trauma-informed care keep mother and baby safe? Because that's what we're doing in the States. We are providing trauma-informed care using a midwifery model because we are trying to offset, mitigate, and handle what women of color, Black women, especially Native women, are having to deal with on a daily basis to survive the childbearing experience. So my model is called the JJ Way. It's a simple maternal child healthcare system built on midwifery, as I said, and we are exploring this possibility. Could creating a culture and an environment that supports all pregnant people make the difference between health, gestational age, birth weight, and breastfeeding rates? We came up with the answer, and yes, the answer is yes, it does. The fundamental premise of our work is simply this: every woman wants a healthy baby, and every woman deserves one. So working from there, we engaged ourselves and looked at how can we be responsible for impacting those outcomes. Very simple. Listen to women, trust women, empower the mother-baby family. The 4 cornerstones of the JJ Way are simple. provide access, create and nurture connections, impart and support knowledge, and thereby you'll end up with empowerment. It's that simple. This is what you get when you apply those tenets, those cornerstones every time. This was a first-time mother. This was another first-time mother. We were all about the big belly, the full-term baby. Look at these women. These are folk from the clinic, everyday folk, everyday families. Even the little tiny women can have a big baby, full-term baby, healthy outcomes. So what we're doing is what we call creating perinatal safety. A perinatal safe spot is a place, an environment, even a person who holds dear to these four cornerstones, providing access and connections, knowledge and empowerment. We utilize this model in the Orlando, Florida clinics, where I have a birthing center, a freestanding birthing center. It's been operational since 2003. And we run women's health clinics, which provide prenatal care, postpartum care, some well-woman care, and sort of interconceptional support. So the birthplace, the easy access women's clinics are providing midwifery model care, but in a trauma-informed way, providing safe and respectful care, maintaining dignity, care that's coming from compassionate, culturally sensitive, non-judgmental caregivers. These are the components of the work. All of these things are free. They don't cost any money to add these to existing services and clinics. And again, look at the outcome. This is a postpartum group. Look at these healthy babies. Look at the thighs and the rolls of fat on these babies. Look at the smiles on the face of these women. This is what happens when you practice this way. So this is a common sense approach to maternity care in an area where you would assume you wouldn't need to go to these extra measures, but without these extra measures, what we get are the disparities and the outcomes that I mentioned earlier. So in order to do this work, we provide community-based maternity medical homes. And we're not just midwives. It's any willing or licensed provider who understands the underlying reasons for these disparities and is willing to provide that reality check and thereby eliminate the disparities in maternal, child, and newborn health. We work with allies. We work with collaborators. We are building our own pipeline. We're building our own workforce because our goal is long-term transformation. We are not going to accept these outcomes any longer. So we provide clinical services, like I say, prenatal, postpartum, interconceptional, family planning clinics. In the Women's Health Service, we provide medical triage, a real important part, because what we do is we determine once we get a patient started in our care, where she really needs to be. Some women do need to be with a high-risk obstetrician. There's no point us trying to continue midwifery services for somebody who is outside of our scope. But we have to triage her first to get her to the right place. We have to work with our collaborators, and we have to build relationships with them. And we have to know how to navigate our health systems for the best outcome for our patients. So we have the birthing center option for women who choose that natural birth with a midwife, but we also have the hospital birth option for women who choose delivery with the physicians at the hospital or the midwives at the hospital. And of course, we offer doula support wherever they choose to deliver. And then we do our outreach, we do our education, we do our support classes. We build into the program wraparound services, not just clinical. And this is what you get. This is one of our studies from 2007, our first study where we showed we were eliminating preterm births in Black and Hispanic women. And if you see the comparison during the time we did that first study, the state and the county were running around 20% for prematurity, 15% for Black women, and 15% for Hispanic Latina women. Outrageous, no excuse whatsoever. So we eliminated the racial disparity. And we had, in that first study, 100 women enrolled prospectively. And the average birth rate was 7.7. The average gestation was 39 weeks. So we knew we could get that outcome. And again, look at these women. Look at that baby. Full-term, healthy, chunky babies. One of our teen moms. Look at the baby. So our education is given one-on-one during waiting, in the waiting room, language specific. We run a clinic in Spanish, we run a clinic in Portuguese, and we run the English language clinics. Our staff, we work as hard for our patients as we do for our staff. Every staff member is empowered and works under those same 4 tenets. They have access to the support and empowerment that they need to do their work, that they are connected, that we work across all disciplines, we respect all disciplines, they have knowledge to do and access to information and training to do their work well, and they in turn are empowered. And that's how we do this. So we provide safe perinatal care the JJ way. Our 2014 study showed that we were statistically significant for longer gestational periods and lower preterm birth rates. There were about 240 women in that study. Our 2017 study showed that our community-based maternity center again came back with a 0 disparity for preterm birth for Black women, as opposed to their counterparts in Orange County, the white counterparts. These are our solutions: community-based, community-owned, community-led perinatal providers and practices using doulas, lactation educators, community health workers, medical assistants, nurses, and midwives. That is protected in all maternal toxic situations. People who are willing to create and navigate the team approach to maternity care, to provide quality and culturally congruent perinatal care, who are willing to train and support other providers and build strong interdisciplinary and collaborative practices. So what do we need? We need access to that safety and quality maternity care for all women. We need access to providers who will work with cultural humility and willingness to acknowledge the true dangers for women. And again, those true dangers aren't always the physiological dangers. They are the underlying racism, the structural inequities, the broken and unsafe practices that somehow keep going forward. And we need access to all levels of care, whether mothers choose home birth, clinic birth, birth center, or hospital. We need to recognize the providers need access to understanding these inbuilt historical and structural harms and the broken systems, the unwieldy medical systems. We need to understand what they are so we can break them down. We need access to the cultural humility training so we can reach in and work collaboratively with these communities we care for and the providers we want to be in concert with. And the students need access to scholarships and grants, loans for training to establish sustainable community-based practices. We have a national task force to do just that. The National Perinatal Task Force is building a movement to birth a more just and loving world. If you go to our website, we have our report that outlines our programs and what we do. This is maternal justice. This is birth justice. This is not just medical care. We are building a network of perinatal safe spots across this nation. We are looking at best practices and evidence-based models for reducing disparities. And we also have a council of midwifery elders, people who've been long in the tooth, who've been doing this work for a long time and have been getting the results. So we are now proud to announce that we have opened the first Black-owned midwifery school, privately owned and nationally accredited school in the United States, the first ever Black-owned midwifery school, independent school. And we are in the business of saving lives, and we are about to just blow it wide open. We are training right now Black and midwives of color to service our communities that are suffering. So again, access, connections, knowledge, and empowerment. This is what you get when you implement work based on these 4 cornerstones, based on doing the right thing, making sure that at the end of the day, we center the mother baby family, the community. We know we can make a difference. We are in the business of saving lives, building and birthing a community of people and power to end disparities once and for all. Thank you so much for the opportunity to speak to you today.